Hello students, I welcome you all to OBGYN with Mackler. So in this module we are going to discuss about the Swyers syndrome. So this is one syndrome which happens in the male population, right? Male population means the karyotype of this patient is going to be 46XY. So it is a male karyotype, but these patients are ideally taken female at birth because of the external genitalia which is going to look like a female. Okay, yes. Now we have discussed about primary amenorrhea with the uterus absent and present. In absent, we discussed two things, and that is going to be Mullerian agenesis and androgen insensitivity syndrome. Now, with the uterus being present, we discussed four conditions. That was cryptomenorrhea, Kallmann syndrome, Turner syndrome. All these three conditions is going to happen in a female, right? So cryptomenorrhea and in Kallmann syndrome, the karyotype was 46XX. In Turner syndrome, the karyotype was 45XO. The Y chromosome was never present in Turner syndrome. But in Swyers syndrome, where the complaint of the patient is going to be primary amenorrhea with the uterus being present, but this patient is actually a male patient. The karyotype is 46XY. Okay, so Swyers syndrome, the karyotype is going to be 46XY. Where what is the other condition where the karyotype was 46XY? It was androgen insensitivity syndrome, which was also 46XY. Right? Okay. So now let's discuss about the basis of the sexual development in male. Let's have a quick rapid revision about this and let's discuss about the syndrome. So we all know that testosterone will get converted into dihydrotestosterone, and dihydrotestosterone is the one which is responsible for the masculinization of the external genitalia. External genitalia has the natural tendency to develop into a female external genitalia in the absence of any other hormone. When the dihydrotestosterone hormone comes into play, the external genitalia will get converted into the male external genitalia, right? Okay, so let's discuss about the testes. Similar to the ovaries, testes also has two types of cells. One is Sertoli cells and the Leydig cells. Sertoli cells secrete an important hormone called anti-Mullerian hormone. So we all know that Mullerian duct is very important for the formation of female internal genital organs. So the function of this anti-Mullerian hormone or the Mullerian inhibiting substance is to cause regression of this Mullerian duct. Is one function. The other function of the anti-Mullerian hormone is to cause the abdominal descent of the testis. Sertoli cells also secretes the inhibin B. This inhibin B has a negative feedback on the follicular stimulating hormone in males, right? Okay. So Leydig cells mainly secretes testosterone at about 8 weeks of the intrauterine life. So the main function of this testosterone is to cause the growth of the Wolffian duct. Wolffian duct, which is also called as mesonephric duct. It is very important for the formation of the male internal genital organs, which are the seminal vesicles, vas deferens, epididymis, and the ejaculatory duct. Testosterone also has a negative feedback on the GnRH and the LH in males. Also, this testosterone is responsible for the scrotal descent of the testis. Is that clear? Okay. So now let's get into the syndrome known as Swyers syndrome. So as I have discussed in the earlier, this is a syndrome which is going to happen in a male patient. So the karyotype is 46XY. But what is the problem in Swyers syndrome? In Swyers syndrome, the problem is whether in the hypothalamus, whether it is going to be in the pituitary, anterior pituitary, or it is going to be the follicular stimulating hormone, the luteinizing hormone, or whether the problem is going to be in the gonads, or the problem is in the internal genital organ. So where is the problem being situated in the Swyers syndrome? So the problem is actually going to be in the gonad. Okay, so patients of Swyers syndrome will have an dysgenetic gonad. The gonad of male population 46XY is going to be testis. Is that clear? Yes, because we have always discussed that when Y chromosome is present, SRY gene is going to be present. When the SRY gene is present, it will activate the development of the testis. So 46XY, the gonad is going to be testis, but the problem is that it is going to be dysgenetic. It is going to be abnormal development of the testis is going to be present. So it is actually dysgenetic testis and it is going to be undescended, because for the proper descent of the testis we need testosterone and anti-Mullerian hormone, but those are not going to be formed in the syndrome. So let's discuss about that. Okay, so here they have told that in Swyers syndrome the testis is going to be dysgenetic testis. Is that clear? Dysgenetic testis. Let me select a different color so that it is very easy for you. So dysgenetic testis. Is that clear? Okay. So when the testis is going to be underdeveloped or abnormally developed testis, then therefore the cells from the testis cannot release the hormones in appropriate levels. Is that clear? Yes. So the anti-Mullerian hormone is not going to be produced. So when the anti-Mullerian hormone is not going to be produced, so instead of the regression of the Mullerian duct, there is going to be growth of the Mullerian duct. So when there is going to be growth of the Mullerian duct, it is going to result in development of female internal genital organ. Is that clear? Yes. So it is going to develop into female internal genital organs. So uterus, fallopian tube, cervix and vagina is going to be produced. Yes. Okay. Now, inhibin B is not going to be produced, or it is going to be produced in very less amount since the testes are dysgenetic. So the negative feedback inhibin B has on FSH is going to be lost. So the levels of FSH and LH will what? It will be increased. FSH is going to be decreased. See, inhibin B has a negative feedback on FSH. Is that clear? Yes, this is going to happen normally. But here, in patients of Swyers syndrome, since the testis is going to be dysgenetic, therefore the levels of inhibin B is going to be decreased or absent. So since it is going to be decreased or absent, therefore the negative feedback it had on FSH is going to be lost. Therefore, the FSH is going to be released and it is going to be increased. Is that clear? Okay. Also, because the testis is going to be dysgenetic, therefore the testosterone is going to be absent. So no testosterone. So when there is going to be no testosterone, there is going to be no growth of the Wolffian duct. So Wolffian duct is going to regress. And testosterone naturally has a negative feedback on the GnRH and LH. So this negative feedback is going to be lost because the testosterone is going to be absent in patients of Swyers syndrome. Therefore, the levels of LH is going to be increased. So FSH is increased, LH is also increased. And for the proper scrotal descent of the testis, testosterone is very important. Since the testosterone is absent in patients of Swyers syndrome, therefore there is going to be undescended testis. Is that clear? Okay, so now with that, we will discuss about the features of the Swyers syndrome. So the gonad is going to be undescended dysgenetic testis. Following that, we discussed that because of the absence of anti-Mullerian hormone, the Mullerian duct is going to be growing. Therefore, the internal genitalia in patients of Swyers syndrome is going to be female internal genital organ. Uterus, fallopian tube, cervix, vagina is going to be present. Let me come back to here again. But now, the external genitalia, since there is no testosterone, no dihydrotestosterone, then the external genitalia is going to be a female external genitalia. So because of that reason, these patients at birth are going to be taken as a female child. Is that clear? Okay. We all know that for the proper levels of estrogen, see, estrogen is very important for what purpose? Estrogen is very important for the proper growth and development of the uterus as well. But here, since the ovary is not the gonad being present in this patient, therefore estrogen is going to be decreased in this patient, or estrogen is going to be absent in this patient, because ovary is very important for the release of estrogen from the granulosa cells. Since the gonad in this patient is going to be testis, therefore estrogen is going to be absent in this patient. So therefore the uterus is going to be hypoplastic uterus. Hypoplastic uterus. Internal genitalia is going to be female internal genitalia. External genitalia is going to be the female external genitalia. Is that clear? Yes. Why female internal genital organ is formed? Because of the growth of Mullerian duct. Due to the absence of anti-Mullerian hormone, Mullerian duct will grow. Is that clear? Okay, uterus is going to be present, but the uterus is going to be a hypoplastic uterus. Right? Okay. So, this is a condition which has no testosterone, no estrogen. So, therefore, breast development is going to be absent, because we all know that the proper breast development, estrogen is very important. Since there is no estrogen, no breast development. Discussing about the pubic and axillary hair. For proper development of pubic and axillary hair, androgens or testosterone is very important. Since no testosterone, no pubic and axillary hair, or scanty pubic and axillary hair. Is that clear? Yes. By discussing about the FSH and LH, we all know that inhibin B has a negative feedback on FSH. Testosterone has a negative feedback on LH and gonadotropin releasing hormone. Since the testis is going to be dysgenetic testis in patients of Swyers syndrome, therefore decrease inhibin B and decrease testosterone. Therefore, the negative feedback which it had on FSH and LH is going to be lost. Therefore, the levels of FSH and LH is going to be increased. in patients of Swyers syndrome. Is that clear? Okay, so since the external genitalia is going to be female external genitalia at birth, these patients are going to be taken at female at birth. So what is the management you can do in this patient is that you can let this patient to be a female child. So what is the treatment of choice? The treatment is that you have to administer estrogen for this patient. Because estrogen is important, because breast development is dependent on estrogen. So following that, you have to give estrogen plus progesterone because uterus is present. So any patient uterus is present, you have to give progesterone along with estrogen for the proper development. Okay, or else it is going to cause endometrial hypoplasia. So whenever you're going to give estrogen in a patient with uterus being present, you have to give progesterone along with that. If the uterus is going to be absent, then you can give only the estrogen for the proper breast development. Okay, yes, and then you have to do gonadectomy in this patient. Since the testis is going to be this genetic testis, you have to do gonadectomy. Similarly, which we have discussed in androgen insensitivity syndrome, the testis is going to be an undescended testis. So, undescended testis, this genetic testis, you have to do gonadectomy. You have to remove that testis. So, you have to do gonadectomy in these patients as well. So, do gonadectomy as early as possible and then give estrogen for breast development, followed by estrogen and progesterone for the proper development for the uterus. Okay. So this is all about this Swyers syndrome. So any patient with complaints of primary amenorrhea, so first let's discuss about patient with Swyers syndrome. So first you're going to do the examination in this patient. So when I'm going to do examination in this patient, what about the breast? The breast is going to be absent. Is that clear? Yes. And while discussing about the external genitalia, what we have discussed, it is a female external genitalia. This was the first step. Second step, you do UPT, it is going to be negative. When you do the ultrasound, the uterus is present, but the uterus is hypoplastic uterus. When you do the FSH, you can notice that the FSH is going to be increased. Is that clear? Yes, FSH is going to be increased. And when you do the karyotyping, it is going to be 46XY. Okay. Yes. So similar features, similar examination features, which is going to be present in another condition is that Turner's syndrome. In Turner syndrome also, examination, the breast is going to be absent, external genitalia is going to be a female external genitalia, UPT is going to be negative, uterus ultrasound, uterus will be present but it is hypoplastic. FSH is going to be increased in Turner syndrome because in Turner syndrome estrogen is decreased, therefore the negative feedback is lost. The FSH and LH is going to be increased in Turner syndrome. Is that clear? Yes, in patients with Turner syndrome, the levels of FSH and LH is increased. So how are you going to differentiate? The fact is that in patients with Turner syndrome, the stature is going to be short stature. But in patients with Turner syndrome, short stature. But in patients with Swyers syndrome, there is not going to be any short stature, no short stature. Also, the other associated features will be present such as low posterior hairline, shield-shaped chest, widely spaced nipples, short metacarpal, small fingernails, no menstruation, poor breast development, coarctation of the aorta, heart defect. The characteristic facial features will be present in patients of Turner syndrome. So this is also a differentiating feature between the Turner syndrome as well as Swyers syndrome. Okay. Therefore, any patient with primary amenorrhea with increased FSH and LH with uterus being present, the differential can be two things. Primary amenorrhea, increased FSH and LH, uterus is present. One is Turner's, other is Swyers. In Turner's, short stature will be present. In Swyers, no short stature. Is that clear? Okay. And then two other condition. Any patient with primary amenorrhea, decreased LH and decreased FSH, uterus present. So decreased LH and FSH can be seen in only one condition of hypothalamic failure, and that is going to be Kallmann syndrome. Okay, and then any patient with primary amenorrhea, normal FSH and LH, uterus is going to be present. Right, uterus is going to be present, but only when you do a local examination you can see a tensed, bulging, bluish hymen. That is a case of cryptomenorrhea. So everything is normal, but on local examination you can see a blue, tensed, bulging hymen. Then it is a case of cryptomenorrhea. Is that clear? Okay. Similarly, any patient with primary amenorrhea, normal FSH and LHS, but uterus is going to be absent. Whenever the uterus is absent, whenever the uterus is going to be absent, but normal FSH and LH, complaints of primary amenorrhea, think of Mullerian agenesis, because in Mullerian agenesis the uterus is going to be absent. Is that clear? In patients of Mullerian agenesis, uterus is going to be absent. So these are the key points which you need to remember about all these conditions. Is that clear? Yes. So until now we have discussed everything about the primary amenorrhea. So primary amenorrhea with the uterus being present, absent, everything we have discussed. So another condition which we have discussed earlier was androgen insensitivity syndrome, where it is primary amenorrhea with the uterus being absent. Okay, so how would you differentiate between this partial and the complete androgen insensitivity syndrome? Let's discuss here now itself. We discuss something called as androgen insensitivity syndrome. So this condition was one where the uterus is going to be absent and primary amenorrhea is present. Is it clear? Primary amenorrhea present with the uterus being absent. How are you going to differentiate this condition? So you can ideally differentiate this condition based on the fact that the patient is going to be complaining of primary amenorrhea. So the complaint of the patient is going to be primary amenorrhea, and the patient will be ideally taken at female at birth, but the karyotype is going to be 46XY. The uterus is going to be absent. But in complete and partial insensitivity, complete is complete insensitivity to the androgen or the testosterone. So because of that reason, all the testosterone will get converted into estrogen. So the breast development is going to be normal in such patients. So breast development is going to be normal, and the pubic and axillary hair will be scanty or absent in complete. Whereas in partial androgen insensitivity syndrome, what is going to happen in partial androgen insensitivity syndrome? Again, the breast, when we take into consideration the pubic and axillary hair as well as the breast development is going to be full developed breast, because all the testosterone will get converted into the estrogen. And since there is partial insensitivity, therefore the pubic and axillary hair will be slight development will be present, where it corresponds to the early stages of development 1 and 2. So here also it is going to be scanty, and the breast development is going to be normal. The only feature is that between complete and partial, if an MCQ is given to you, the only differentiating feature between the complete versus partial androgen insensitivity syndrome is that in complete androgen insensitivity syndrome, the external genitalia is going to be a female external genitalia, because there is complete insensitivity to testosterone, complete resistance to testosterone. Since there is complete resistance to testosterone, it is a female external genitalia. But in partial, there is partial resistance to the testosterone. Since there is partial resistance to testosterone, therefore the external genitalia will be an ambiguous external genitalia. What is ambiguous? We can't come to a conclusion. So because there will be a female external genitalia, but features of masculinization, little bit masculinization will be present. What are these features of masculinization? Let's say, for example, clitoromegaly. the clitoris will be very big. So clitoromegaly is a feature of masculinization because only partial resistance is present. Partial it is sensitive and partial it is resistant to testosterone. So because of this partial sensitivity, little bit masculinization of the external genitalia will be present, and that feature is going to be clitoromegaly. So clitoromegaly, features of masculinization of the external genitalia. This is a feature which differentiates between the complete and the partial androgen insensitivity syndrome. So until now we have discussed everything about the primary amenorrhea with the uterus being present and absent. So I've also given the hint in any question with which the examiner is going to be asking you, be it in either competitive examination or else in your university examination as well. So we have discussed everything about primary amenorrhea. In the next module, let's discuss about the secondary amenorrhea and its management as well. So please keep studying. Until then, if you have any doubts, please write to us in the Mackler handle.